slurring? Why are you slurring? Raise your arms up in the air for me.
Are you okay?
Gracie, call 911. Honey? Tim! Tim, look at me, Gracie. Tell them to hurry. Tim, look at me, Tim. Dad, I think he's having a stroke.
I think my dad is having a stroke.
Tim, what's going on, baby? My husband, he. It's cold. Are you cold, honey? Are you cold? Okay. Gracie? See, Gracie's gonna come, sweetheart. We're just gonna go in the ambulance right now. We're gonna go to the hospital. Okay? Okay. Huh? I'm right here. Gracie, meet us there. I'm right here. Okay. Okay, here we go. You just stay right here. You just stay and breathe. Just breathe. Tim?
Dad?
How you feeling?
I'm fine.
Well, you've had a stroke. But because you got here quickly, you're looking at a full recovery. Two stroke syndromes. Why is this important? A couple different things. So, stroke is one of the two things that are guaranteed in every emergency department where we call it code 2, because time is brain, time is also heart, time is also testicle or ovary if we're talking about ovarian or testicular torsion. We're on a tight timeline. We have too much time where there's not enough blood flow, then bad things happen. So in the US, somebody has a stroke about every 40 seconds. And in a big place like VMC, I probably hear at least 5-6 strokes called over the overcom, and that lets neurology know, let's get down there. Trying to make big headways with this as far as stroke centers. Being able to call a stroke out in the field with how significant it is determines what hospital they're going to take that patient to based upon the capabilities. Yes, everybody's going to have aspirin. Everybody can give thrombolytics, but you have the neurosurgery capability to go in and pull a big stroke out. Somebody pull a big clot out of their brain. So all that stuff is dependent, but about every 4 minutes somebody dies from a stroke. So pretty significant thing. When you get to your phase 2 site, say, hey, can I look at the stroke protocol? There's usually a whole packet. And when you call code stroke, nurse is gonna come out and start checking things. They're gonna put timelines on everything. We'll talk about those timelines and how important those are, because timeline, when that stroke occurred, is very important. I was glad in that video, thank goodness the wife jumped in the ambulance with him, because she's able to go to the emergency department and say, this happened at this time. Because that determines what the treatment capabilities are, what we can do with that. Look at that, sweet, yeah. Okay, reference material. Here's your objectives. Please review those real quick. All right, here's your pearls, take-home points. Just a reminder, in that person stroking out, we always still need to maintain their airway, breathing, circulation, your primary survey. They're usually pretty easy to knock that out in under a minute. But we want to make sure that we don't need to, as you go down the line with that primary survey, if you have any issues with those, you need to be doing some type of intervention. If their airway is not intact, then we need to be doing something, whether that's an NPA, OPA, an ET tube, breathing, maybe they need to put on O2, circulation, obviously starting an IV, most of that stuff. Hopefully if they're stroked out, they're coming in, EMS has done most of that stuff already. You know what's coming in and have an idea of that. So, big stroke centers, level 1 trauma centers, level 2 trauma centers, they have their stroke protocol down pretty good. So downtown Harbor, you call code stroke. Neurology's right there, along with the ER doc, meeting the patient. As they're rolling them on the gurney to go to the CT scanner, the ER doc and neurology, they're doing the neuro exam right off to get an idea of how bad is the stroke and where it's at. We get them in the CT scanner right away because we have to differentiate between, is this a hemorrhage stroke or an ischemic stroke? So, because if it's hemorrhage, we need to control the blood pressure so they don't bleed worse, and then we need to get them to see a neurosurgeon. That's off the bat. Now that's a small percentage. The biggest one that you're gonna see are these ischemic strokes. So we get that CT scan right off the bat to determine which way are we going. Hemorrhagic stroke, ischemic stroke. As long as it's not hemorrhagic, then it turns into a timeline type issue. So 3 hours is the standard right there that we need to identify that stroke. That's our 3-hour window to give thrombolytics. So somebody's gonna break down that clot and hopefully allow reperfusion to that portion of the brain. There's some studies, again, this is gonna be your MTF that determines that, have pushed that out to 4.5. Evidence-based medicine. Evidence-based medicine, just be aware of that. But nobody says more than 4.5 hours. So thrombolytics, 4.5 hours from their stroke, no thrombolytics, no thrombolytics. This should send the point home to you. And I have another slide just to expound upon this, elaborate, clarify. So it says without bleeding, so we're going towards ischemic. So that means we need to look at timeline. What are our two options for treatment?
Aspirin, thrombolytics,
Thrombolytics.
surgery,
You're not giving
Thrombolytics or
aspirin.
aspirin?
They say.
You're giving aspirin.
Aspirin. Now, what's our timeline on this?
Don't know.
Questionable.
5 a.m.
The night before, that was the last time we knew the patient was normal. We based that upon the time they went to sleep. That was the last time they knew. I don't know if she stroked out 10 minutes before after she fell asleep, or she stroked out 10 minutes before she woke up. I can't windage that. I'm not gonna risk it. So this patient gets aspirin only. Aspirin only. I had when I first got to BAMC, I had a lady come in. I can't see anything out of my left eye. Well, when did that start? 2 days ago. Well, what did you do about it? And I woke up, I just went back to sleep. I thought it would go away. Yeah, CT scan, temporal artery stroke. What did she get? Aspirin, gets admitted for a full stroke workup. Damage is done. There's nothing I can do about that. She decided to come too late. So that's why it's very important that we identify those things. The fast is the quickest way. That was in the video. And we need to get that person. Time is brain. So this person gets aspirin. Quick familiarization. No, I'm not going to ask you questions on pathophys. Majority of stuff is going to be management, treatment focused, maybe some presentation stuff. So any disease process interrupting the blood flow, and then we talk about the substrates that the brain needs to work on. If we interrupt the blood flow, it's not getting the glucose it needs, not getting the oxygen it needs, so it's not running. So, and then we have all these secondary side effects that start happening. You get cellular injury, which then it starts swelling, mass effect. Things can get even worse. Now the brain's getting more and more ischemic, more and more ischemic. Like I said, hemorrhagic, very small amount, 13% total. Majority of what you're gonna see is ischemic. But the last thing you wanna do is push thrombolytic and you didn't get a CT scan, or the radiologist read it wrong and now you're pushing thrombolytic based on a CT scan. By the way, if somebody calls code stroke, that CT scan is gonna get bumped to the front line in front of everybody. And I'll talk about those timelines. But you got the 3 flavors of ischemic, your 2 flavors of hemorrhagic. I'll elaborate a little bit more on those. For the visual folks here, so I have highlighted stuff there that just to give you an idea what I want you to pay attention to out of this slide. Obviously thrombotic being the most common. That's the most common causes of TIAs. Transient ischemic attacks, those are just precursors They're mini strokes that typically resolve, but the more those happen, the more they get concerning. Those come and go, again, transient. Embolic, something breaks free. That's typically like a vegetation that's in the heart, whatever. If you think about people that have embolic stroke, somebody that maybe went diving and surfaced too quick, those types of things. And then your hypoperfusion, that's typically due to whatever reason, the sepsis that causes severe hypotension. Maybe they bled out, they're bleeding out, extravasation, and then heart attacks, just heart's not pumping properly. So you're typically going to see hemodynamic factors with that. Here's your hemorrhagic. Intracerebral, a lot of these have to do with people with high blood pressure. So these are parenchymal type of bleeds. They're not going to be on the outside of the brain, like a subdural or epidural. Other types of things, obviously, people that are anticoagulated, we get worried about those. AVMs, malformations, and then we throw in the cocaine use, we talked about that. And then non-traumatic, not very often, so that's about 3% from that first slide. 10% on the intracerebral, 3% on that. So, early detection is key to prevent, that's M&M, that's morbidity and mortality, death and quality of life. Time is the critical component here. Similar to MIs, they don't quite have exact timeline on testicular torsion because that can torse and detorse. How do we fix a testicular torsion? Open book. Okay, but typically that doesn't work out. It's never really worked out well. That needs to get taken to the OR. But very important, like the video, that somebody comes along there can tell because that person's stroking out. Probably maybe can't speak, slurred, can't remember. Definitely like freaked out because they're not sure what's going on. Unless it's like their third stroke and they're like, oh boy, here we go again. But it's good to do that. And then EMS, making sure they're letting that receiving facility know I'm bringing somebody in with a stroke. So get ready for that. Do they call a stroke and that person comes in and EMS failed to get a glucose? Absolutely. I told you don't look like a knucklehead. That person should be coming in the door. Hopefully EMS already got the glucose and they say, hey, glucose is 90. Now you're like, yeah, definitely stroke. Versus glucose being something that we need to intervene from. But EMS comes in, you should be the first person that's right there to receive report. Because if you're not there to receive report, they're gonna drop the patient off the gurney, they're gonna get out of there. Don't wanna be hanging around too much. Some are good people and will hang around, make sure that you get a report, but they got stuff to do. They don't wanna hang around the ER too much. So, right here, all these pre-hospital stroke scales, just great ways to initially assess somebody. I'm not worried about the other two that are on there. The biggest one is going to be the Cincinnati pre-hospital score. That's the FAST. So accurate diagnosis needs to be focused, history, and physical. There's that FAST portion, so facial droop, arm drift, slurred speech or abnormal speech, and then the T, we need to know the time. Absolutely. Put time on a tourniquet, right? It's important. Put time on a stroke too. Time on a stroke. Now there's a very interesting thing if you think about pathophysiology of stroke. Based upon where that clot specifically is going to give kind of some variable types of symptoms. Sometimes it can be a little bit ambiguous. So you have things like general weakness, lightheadedness. Those are the things that I hate when patients come in. Oh, I feel dizzy. Or I feel weak. I'm like, what does that mean? It can be any number of things. So maybe you're missing a stroke, but some people have these vague sensory changes. Altered mental status. I do get concerned, yes, females do present a little bit more atypically. So, non-traditional symptoms. I come in, I just feel dizzy, I'm having vertigo, and you're thinking, oh, this is just like an inner ear vestibular type thing. No, you could be having a stroke. So, diabetics, women, females present very atypically. These are just some generalized features. Again, folks that like to look at something to learn. See some very interesting things here. So like the generalized, I just feel weak. I know what's going on. You're older, high risk for stroke. Sudden hiccups, that's a crazy one. I'm not gonna test you on any of the specific stuff, I just want you to realize that based upon where that clot is, can change the variability of what their symptoms are, what they're coming in with. Some of it's standard, left-sided hemiparesis, facial droop, slurred speech. Those are your standard ones, but we can have all these other funky stuff that's thrown into there, makes it very difficult. How do those embolic and hemorrhagic strokes? Sudden onset, bam, hits them. Versus our thrombotic and hypoperfusions. Have this waxing and waning kind of transient type things. You think, man, is this a TIA or is this a stroke? It's a little wonky. So again, aneurysms, very concerning with Valsalva. Very concerning with Valsalva. Headaches. And then cervical artery dissection, we'll take a deeper dive into that. I get concerned about those with recent neck trauma and manipulation. Person comes in and saying they have a headache after they just got manipulated by their chiropractor, and they're like 80 years old. I'm like, oh boy, I hope we're not dealing with this, but have that on your differential. There's usually some type of neck insult, trauma, manipulation with that. So, how does that thrombotic thing work? So blood clot is formed in situ, meaning it's happening inside of the brain. Here's your risk factors, definitely high blood pressure. Why do you think diabetes causes strokes? So unfortunately, it's excess glucose that's running through the body causes fatty deposits and increases blood clot formation. So diabetics, I think it's not that crazy. Oh, I just gotta check my sugars, I gotta watch what I eat. No, I'll put you at higher risk for a whole bunch of things. Heart attacks, strokes, and obviously CAD. If you're having fatty deposits inside the arteries, the heart, you're gonna have fatty deposits inside the brain. Makes sense? It's happening there, it's happening other places. Versus your embolus. Now that can be any number of different things, 4 different flavors there. And that usually breaks free. And what does that happen? Atrial fibrillation. What do people on that have atrial fibrillation? They're anticoagulated, they have to be, because they throw clots all the time. And that clot can go to lung, that clot can go to brain. You're concerned about that. Any valve replacement. And then recent MI, why? The heart's not pumping properly, so you had some type of damage to the heart wall where it got ischemic, it infarcted, it's not gonna beat the same way ever again. So high risk. I'm glad a lot of you already had an idea. It was the last time the patient was known to be at their baseline. Somebody goes to sleep and they stroke out some point in their sleep and they wake up whenever they went to sleep. Which typically that is going to make, nope, not happen with thrombolysis. Not gonna happen. Not gonna happen. But again, it's the art of medicine, it's the science of medicine. But we say we practice medicine, which is why we gotta be aware of these mimics. Similar to the reporter that was a migraine, I would have said, well, maybe that's not a migraine, that's just a mimic or that's a stroke. But that can go back and forth. We have all these different things there. Just be aware, that's why I want you to cast your nets wide. So if it's not on your differential, probably not gonna diagnose it, unless it's flat out on the radiology report, right? Like CT scan says, oh yeah, there's a thrombotic stroke at the MCA. Awesome. Well, you should have caught up on that, but we wanna make sure we're taking all these other things. And a lot of things, if you're calling a code stroke, they're gonna be getting after all this stuff. But what do you wanna do? You wanna call it a code stroke, or you just wanna call it a migraine when it was actually a stroke? So I'm saying if you're on the fence, pull the trigger. Pull the trigger. Make sure we rule out that hypoglycemia. Okay? Make sure we rule out that hypoglycemia. Top priority, and then just start thinking as you're working up that stroke, just make sure we're covering all our bases and not missing any of those things. Very difficult in a stressful situation when you're calling a code stroke, because neurology's gonna get down there and they're gonna have all kinds of questions for you. How do you gather that information? Hopefully they came with a witness, hopefully they came caregiver, spouse, son, daughter, whatever, comes with them that can give you all that stuff real quick. I mean, I've gotten pretty good where I can just look at the med list and be like, okay, hyperlipidemia, coronary artery disease, diabetes. Very difficult when you're on a timeline here, quick timeline. So most of these folks are gonna get an EKG right away as soon as they come back from the CT scan. Chest x-ray, CT. Just wanna make sure that there's not other risk factors that are related to any vascular or cardiac disease. So, there's an app for this. You can do it on your phone real quick, because I doubt anybody's gonna be able to remember all of this stuff. MD Calc also has a little thing, you can just rattle it off and come up with a score. If neurology's not there at the bedside, because you're at a smaller MTF and they're working their way down there or whatnot, it'd be nice to have all this information real quick, and you just pull up on MD Calc or any number of apps, and you can rattle these things off, because you need to determine level of consciousness, extraocular movements, visual fields, facial palsy, arm drift, leg drift, limb ataxia, sensation, language aphasia, dysarthria, inattention. That's all gonna base off of that, give you an idea of that score. Was that score correlate to how bad their stroke is and what type of options that we need to look at right here. So, severe stroke, anything higher than 21. Anything higher than 21. I'll talk about a little bit more about where the kind of the sweet spot is as far as what we're looking for thrombolysis, thrombolytics. But for now, we'll get into ischemic stroke syndromes. Anybody have any question on kind of the pathophys and how that works? That's just more of a background. I'm getting crazy on testing this stuff. So ischemic strokes, where do they happen at mostly? Where's the number one spot? Good. So MCA, most commonly involved. So again, I talk about where that lesion location is. If it's more proximal, we're gonna have more symptoms. More proximal to the heart, okay? More distal, it's gonna have less symptoms. Makes sense. So, typically, it's gonna be hemiparesis, so one side of the body is gonna work, the other side's not. Facial plesia, so that's that facial droop. Aphasia, very common, or slurred speech. Again, if it's more proximal, they're gonna have aphasia. More distal, it'll be more slurred speech. And then sensory loss on the opposite side. So, really, really wonky. So typically more upper body than lower body, just be aware of that. So you may have somebody that can't move their arm, but they can move their leg a little bit. Just be aware it's more of an upper body type of thing. Visual. You see right there where that is. Arrow's kind of a little bit wonky, but it's that black arrow there. That's where that happens. Again, if it's more proximal, more damage, more symptoms versus your posterior. So, anytime that we're talking about anything posterior in the brain, you need to be thinking that it's going to start affecting more of things like ataxia, imbalance, vertigo. If we're affecting that, we're going to see a lot of signs of nystagmus. What do you think that nystagmus is going to be? Is it going to be going left to right, horizontal, or more vertical, up and down?
Down.
Vertical. Okay. Peripheral causes horizontal nystagmus. Central causes more concerning. Vertical, up and down nystagmus, much, much more concerning. So again, it can be subtle based on where exactly that clot is. So, ipsilateral cranial nerves affected, opposite side, motor weakness. So, what does that mean? Same side of the strokes, typically gonna have facial symptoms. Opposite side of the body will have the motor weakness. So, again, other types of symptoms, this can get all really wonky and mixed up. But these are just some other types of things. I'm not gonna get super in the weeds with a lot of this stuff, but I would definitely pay attention that if it's posterior in nature and there's a couple other little spots, arteries that are close to this, you gotta be thinking that that's gonna start affecting their balance, ataxia, nystagmus, all those types of things. These people have trouble walking. So you can have all these other type of symptoms. Here's where that posterior stroke happens. So that anterior, which is just kind of to the left, superior to that, and this is going to be the posterior. What can also happen with this posterior? Cerebral artery infarction, so not hemanopsia, and I'll show you a picture of exactly how that looks. That's where somebody loses vision, both eyes, just either to the right or to the left based on which side of the brain that stroke's happening. So, kind of weird. I think it's a weird thing that these folks can have lost ability to read, but they still have the ability to write. I don't know how that works, but it's crazy. Can't name colors. This hemibilismus, this is a type of chorea, so they are literally going like this, whichever side that stroke is. And a wonky thing, if you ever want to look up something, there's plenty of YouTube videos, and you're like, what the heck is that? I want to see it for real. And they'll show you people that actually have that issue. So large amplitude flinging movements, really wonky. But here's just a quick thing. Here's how that turns out, that posterior cerebral stroke. Now we have basilar arteries. So unilateral limb weakness, meaning just one. These people are going to have that slurred speech, dysarthria, not going to be aphasia. These are these people that have that Babinski sign. So I want you to pay attention with that. That's why we actually do that. Not just because we want to see if somebody's ticklish. It's actually used to check to make sure there's no basilar artery infarction. Again, these all kind of run together because there's that vague idea of dizziness. Again, somebody comes in, says dizziness, they're older, I've always got stroke. I want to make sure I'm eliminating that. Worst case scenario, I want to think that I've taken that off the plate. Here's where that happens. Again, dysarthria, slurred speech with these folks. I want you to pay attention to that. And the Babinski sign, those are probably the biggest things I want you to take out from that. So, dysarthria, Babinski sign out of a basilar artery infarction. Here's what really stinks though, is when they have this. I can't think of anything like my worst enemy is to have this. Very rare, but they all cause this locked-in syndrome. This is terrible. Complete muscle paralysis, except for they're gazing up and blinking. Can't respond, can't say anything. I forget that's what happens when you give somebody a paralytic with no sedative. That's terrible. These people typically do not make it out. There's ischemia with the pontine area of the brain. That's considered a catastrophic stroke. Catastrophic stroke. No bueno. Versus your cerebellar infarction. Again, where's the cerebellar? Where's the cerebellum? Back of the head too. When I talk about anything posterior, I told you we're gonna have these weird types of dizziness, imbalance, vertigo, ataxia. So that fits right in with this. So if you're not thinking just posterior, am I gonna say, well, differentiate this posterior from this cerebellar? I'm not gonna do that to you. I'm not gonna do that to you. So there would be neurologists that would have difficulty figuring that one out. Just keep them both on your differential. Keep them both on your differential. So very wide a range of whether or not that patient is comatose versus alert and talking to you. Here's the crazy thing. So the cerebellum's all wrapped in bone and spine, very difficult to look at. So a quarter of those get completely missed on CT scan. A quarter of those get completely missed, which is why when I have somebody that comes in with symptoms like that, ataxia, or things like, oh, this is really messing with their balance and vertigo, I get a CTA as well, because CTA is going to look much more posterior than just a CT scan. Yeah, we have to get the CT scan, we have to roll out the hemorrhagic stroke. But I'll get a CTA if I have any inclination that we're going towards a cerebellar, or a posterior, or a basilar artery, or a vertebral artery stroke. I throw that on there as well. Now, see it says follow up with a CTA. I'm like, sending them to radiology already, and it's a CT scan, let's just knock them both out at the same time. So, get an idea of that. So unfortunately, yeah, cerebellar infarctions are a tough type of thing. And if it is cerebellar, we need to get neurosurgery on board. Neurosurgery on board. If it's a cerebellar stroke, we need to call neurosurgery. Anybody know what a HINTS exam is? So this has gained a lot of popularity because they're actually catching these better than they are catching them on CT or CTA. So that stands for Head Impulse Nystagmus Test of Skew. You can look it up on the internet. Head impulse, you're simply holding their head to the side, tongue to look, jerk it real quick to the end. They should stay locked in with your eyes the entire time. If there's a little bit of lag where it takes them a second to lock back in, that's positive. Nystagmus, what are you looking for? Vertical nystagmus. Test of skew, very simple. Cover one eye. Tell them to keep looking. If one eye deviates, test of skew. So, having a lot better success with that for cerebellar infarctions. Now, this other thing, when I talk about these, neck trauma. Somebody gets judo chopped by Austin Powers. Okay, probably going to suffer a carotid vertebral artery dissection. So these are younger folks that are coming in. Typically some type of minor neck trauma. Judo chop, I also talked about the chiropractor and things like that. Maybe somebody's out wrestling with their dog and tweak their neck. Very concerning. Connective tissue issues with Ehlers-Danlos, whatever they might have, migraine history, hypertension, all risk factors. How does it also look right here? Unilateral frontotemporal headache. Again, somebody comes in with a headache that sounds like, well, maybe that's giant cell arteritis. Oh, maybe that's a tension headache, I don't know. But we need to do a good eye exam. So, eye meiosis, what does that mean?
Small pupil.
It's tiny, right? Constricts. Ptosis, lid lag. Okay. Hours to days. So CT angiogram, CTA for this as well. Symptoms can wax and wane. Here's how that can kind of look. So they have that partial Horner syndrome. So see how that left eye? See how small a pupil is? Meiosis. So anhidrosis, meaning that they are sweating, right? Is that right? Right. Dyshidrosis would be sweating. All right. You guys are paying attention. Good. So dry to that side, and then ptosis, have lid lag, carotid artery dissection. This can progress to causing problems with the eye. Rare, but can progress to more cerebral infarction. Now here's your vertebral artery dissection. Again, this is more of a posterior type of thing. Vertebral deals with the vertebrae. So dizziness, vertigo about 60%. Neck pain, not to be associated with trauma. Headache is typically in the posterior, it's in the occipital portion of the brain. So again, this typically is going to affect posterior circulation. Remember, anything posterior, we're dealing with dizziness, vertigo, ataxia, nystagmus, any of those types of things. Vertebral arteries are considered posterior circulation. When I said posterior, I do combination CT, CTA. Combination CT, CTA. Am I going to get the MRI? Yeah, if neurology tells me that's what we want. I'm just not going to call radiology and be like, says who? Like, well, neurology wants it and they're going upstairs. Okay, no problem. Radiology doesn't want to battle two different providers. We'll take care of that business. Questions on ischemic strokes. We'll get into treatments and all that stuff. This is your general physical exam findings presentation. Hemorrhagic strokes, again, 13% less likely. We get that CT scan right off the bat. CT scan. But unfortunately, you don't want it to be hemorrhagic stroke because these have way more higher morbidity and mortality. So again, we get that CT scan, we need to get that off the plate. Typically preceded with the symptoms of a stroke, these people are going to have headache, nausea, vomiting. Kind of differentiate between that, whereas that thrombotic is typically waxes and wanes, but this one's preceded a little bit of a prodrome of headache. Yes, we can have hemorrhages in the same spots where we're having ischemic events. Very difficult. Again, we can't image that cerebellar area as well, but initial, when you get that CT scan. But like I said, very difficult to see this, especially if they're hemorrhaging in that area. Like I said, normal CT, what I see, what percentage? 25% of these are not gonna pick up on that. That means even more with hemorrhagic stroke. If you're really concerned about that, yeah, you can push for it, but in conjunction with your neurology partners, you're gonna say, hey, we want an MRI. By the way, anybody that comes in with a stroke at some point, and they're coming in for a stroke, they're going to get an MRI. It's just a matter of whether or not we need to move that timeline up. Talked about this already. So subarachnoid hemorrhage can have the same symptoms as a hemorrhagic stroke. I've talked to you about this type of thing. Strenuous activity, somebody comes in, whether that's weightlifting, running, intercourse, however. Time is brain. So we need to make a decision. There's one of your first timelines. So 60 minutes, door to needle time. What does door to needle mean? Time to or pushing thrombolytic. Time pushing thrombolytic. Door to balloon time. If we're talking about MIs, what's that?
Time to the cath
Time
lab.
that they're gonna go in and decide whether or not they're gonna put a stent in there. Okay, door to balloon, this is door to needle. I'm gonna call it code stroke. If you're on the fence, call it. Stroke team's gonna come down, neurology. If you're in a teaching institution, you'll probably have like 5 residents and attending. It can get pretty crazy. So you don't wanna delay that workup again. You start that timeline, the paper comes out. For Genesis, all you have to do is hit a button and it orders everything. So they have things pretty well set up. Now, it's not the greatest EHR or EMR, however you wanna do that, electronic medical record versus electronic health record. Yeah, military went lowest bidder. There's a lot of better ones out there, but it's what we got. At least it's all one system. You're not bouncing between CHCS and Alta and whatever else. And then you got a whole other pack, so you gotta look into. At least it's one system that looks at everything, and the entire hospital uses it, I will say that. Try and get as much time as you can in phase 2 on those. It'll behoove you so you don't have to beat your head against your computer when you're trying to see patients as a brand new PA. It just complicates things. This is all the continuum of the emergency department that I talked about in that first lecture. The continuum. Everything's kind of happening concurrently. Nurses are drawing labs, you're making a decision, you're talking neurology, they're doing their thing, they're talking to their attending. So all these types of things are kind of happening all at the same time. By the way, that person just came in by stroke, you're calling code stroke, you're trying to get information from EMS, trying to get a good history and physical, you're trying to determine what are my inclusion and exclusion criteria for thrombolytics. What's the timeline looking at? And by the way, I gotta get them a CT too. So it's just a whole bunch of things. Some places that see a lot of stroke have it down to a science. They run through it, and then people have done it plenty of times. I'm gonna tell you, first couple times, if you do this, it's gonna be rough. It's gonna be rough. You're gonna maybe like, what do I do next? Run through your processes in your head, like, how should this play out? The good thing is most people have that stroke protocol. They're like, okay, we do it like this. This is the way we go. Here's your timeline stuff. That non-con, like I said, places that see lots of strokes, that person comes in, they go right to CT, because that's timeline. CT done within 20 minutes or less. Ideally, that's done within the first 10 minutes, 20 minutes or less. So what I say, 60 minutes we have before we need to be making a decision on thrombolytic. Because what if that person comes in and they're at 4 hours? Oh crap, I'm gonna go over the 4.5 hour mark, yikes. Again, get that done. And then 45 minutes before that radiologist needs to have that read. So I know where the radiology department is. Yeah, they like to hide out in certain areas, dark rooms, listen to techno music, most of the time. But at least know where they are, because as soon as I get that CT scan, I'm right at the door like, can you read it real quick? Let me know, because I need to make a decision. Is it hemorrhagic? Okay, cool, it's not. It's ischemic, sweet. Okay, I got a ball game. I can walk back in and start making some decisions. Make sense? Make sense? We'll add some check on learnings to settle those points in. So MRI, very limited. Keep in mind with an MRI, somebody's been waiting 3 months to get an MRI in a suite. So if we have to bump them from their appointment, they've been waiting for 3 months, we better have good damn reason why we're gonna bump them out and put this person in the MRI. By the way, MRIs, 45 minutes to an hour. Think that person's got an airway issue, if that's gonna be cool? No. I've gone and sat in the MRI though, with a patient bagging them. That's the way it needs to be, so. Anyway, that's the only imaging necessary in most emergency departments required to give in TPA. Want to make sure it's not hemorrhagic. Making sure they're maintaining their airway. Want to maximize on their oxygen intake. And then if we get those labs back, hopefully you've got an iStat on them, so you can look at if there's any abnormal electrolyte disturbances that we can correct real quick. Maybe we need to give them some normal saline, maybe we need to hang some potassium, whatever, we need to fix those types of things. What are some common things you're gonna see associated with strokes that you wouldn't think about? Right there. People stroking out for whatever reason, they have hyperpyrexia. They develop a fever. That fever develops, it increases their morbidity and mortality. So that has to do with increased metabolic demand of the body, because the brain's not getting what it needs. But we also want to make sure there's not other stuff that we're missing. Standard for these people to get a UA, you do a good physical exam at some point, where they are, definitely naked. You want to make sure that there's not some underlying ulcer, cellulitis, whatever. Chest x-ray, rule out pneumonia. That's typically done bedside. We do not give these people NSAIDs. We do not want to mess significantly with their coagulation cascade. Do not want to mess with that. So, IV Tylenol. Yeah, it's expensive. I don't care. It can come out of my pocket. So, go ahead and order that. Typically give them a gram. IV. Piggyback, however. No NSAIDs. Avoid ibuprofen. So ibuprofen does not help in these particular patients, and we're only going to increase the risk of bleeding. What do we do with that? So patient's not a candidate for thrombotics or reperfusion. What would make them not a candidate? We'll get into that a little bit more, but right off the bat, what?
Bleeding.
So hemorrhagic, or they're out of their time window, right? Those are probably two big things. Permissive hypertension. So we don't want to lower the blood pressure unless it's higher than 220 or diastolic higher than 120. That's called permissive hypertension. That's allowing maximum perfusion to the brain. When it's ischemic stroke, we don't necessarily want to get after that so quickly, but we want to lower it slowly. But that's if they're not a candidate for that. If they are a candidate for reperfusion, so they're within that window, we know it's not a hemorrhagic stroke, we want to get that blood pressure below 185 over 110. If we can't get it under, then they're no longer going to be candidate for thrombolytic. So we want to get them down. And how are we going to do that? Again, no dosages, but there's your 2 medications you're typically going to lower blood pressure with. So labetalol, which is what class of drug?
Beta blocker.
Good. Nicardipine?
Calcium channel blocker.
Calcium channel blocker. Good. Those are the 2 things that you're going to reach for. But again, I give you those as the options. You pull out your stroke protocol at
Yeah,
whatever
it's a DHP.
hospital you're at, and they may say, here's the only thing we're going with here. Cool. So you follow that. Most of the time, you're just going to sit back, call this code stroke, get all the information you can, do your thing. most nurses that have run plenty of strokes before have everything pulled up. So, you have some really good nurses. I mean, I've had a patient come with anaphylaxis, and they're like, I already got the epi pulled up, famotidine, diphenhydramine, and how much solumedrol do you want? Like, they've got it pulled up and they're ready to push. Usually not gonna let you fail, it's a team effort. Here's another wonky thing that can happen, hyperglycemia. So we wanna maintain that blood sugar there. Make sure it's not hypoglycemia. Okay, these can be, either can mimic a stroke, either too high or too low. So but hyperglycemia can show up very quickly in acute stroke. It has to do with stress. Stress causes the release of cortisol and norepinephrine, causes that blood sugar to go up. It's a stress, fight or flight type of reaction. Now, aspirin is what we're gonna reach for unless thrombolytics. If we reach for thrombolytics, we don't need to mess with aspirin for at least 24 to 48 hours. But not a candidate for thrombolytics, we need to give aspirin. So aspirin for TIAs for sure. And since one other thing that we will add to that, I'll talk about that when we get more into TIAs. But generally aspirin if they're out of their time window. So we have to know that timeline. I'm reiterating on this because it gets missed. Some of this stuff is for your benefit, but the other benefit is I still have people, every question that I give almost in phase 2 is from a phase 1. And people just, whatever, dumped it. So, still have people missing this, and they wanna give thrombolytics when somebody went to sleep at 10 o'clock at night and woke up with a stroke symptom. So please, 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 clock from the time the patient was last known, AKA before going to sleep. Sorry for being repetitive, but it is what it is. Now here's your indications and exclusions, because it's not just time window. There's other things we have to be concerned about. There's a lot of different things. But there's your sweet spot when we talk about the NIHSS scale. So score between 4 and 22. Why? Because if it's above 22, between 22, 23 and 42, that person probably needs to see neurosurgery or interventional radiology and get that clot pulled out because it's too massive. That means that thrombolytics are probably not going to do much of anything for that because it's such a massive clot. So that's the sweet spot right there. Here is your inclusion criteria. Obviously, you need to be over the age of 18 or above. We're looking at less than 3 hours again. That can be extended to 4.5. Am I gonna put you in that realm of over 3 hours and under 4.5? No, I'm not. Be very clear if we're doing that. And then of course, we're looking at that sweet spot. Poor outcomes if they give thrombolytic in over a stroke scale of 22. And that's great, you have your inclusion criteria. Well, now we gotta watch this. Exclusion criteria. Platelet count less than 100. Now, if you're in your window, do they say go ahead and push thrombolytics and you're still waiting on your labs? Yeah, if you have your, when you're within your window and that platelet count's not gonna come back, sure, get it. So, and then all these other labs. But the biggest one, obviously you're not gonna give thrombolytic to somebody who's actively bleeding. Now, is that a difficult thing to figure out? Sure. What I want you to pay attention to is, I'd say, out of all those types of things, the number one thing that's concerning to me would be pushing a thrombolytic on somebody who has a history of a previous intracranial hemorrhage. Wouldn't that seem like probably the worst thing you could do? This person's had a hemorrhagic issue, whether that was a stroke or a bleed, and now you want to push a thrombolytic on them. So, if I were to see that at some point in the near future, that'd be my go-to. Yes, I know it sounds crazy. Yes, we do get a blood glucose before TPA. That makes great sense. But that's also to get a baseline. Because if that patient does start getting some hyperglycemia, we know we need to control it. Or if they get hypoglycemic, we need to give them some D50. So, again, they say do not withhold that, even though that's exclusion criteria. I'm not going to get muddy in the waters with you guys right now. Medicine does get pretty muddy. It takes experience and some sound judgment from time to time. But There's your dosage. That I just want you to know that you give a small dose at first, so 10% over the first minute, and then the next goes over 60 minutes. Just have an idea of that. It's not like I'm just pushing thrombolytic. There's very few things that we push very quickly. Adenosine is one of those things we don't mess around. That is slammed in. No pressure bag other things in, but just give you an idea of that. TPA. You'll get pimped on this for sure in phase 2. So no, for phase 2, I don't need you to know it. Dosages for the test. Again, I told you I need you to know concepts. Again, anybody that's concerned for a stroke is going to the ICU. So while they're down in the emergency department, they're getting BP and neuro checks every 15 minutes, especially after that thrombolytic. Want to make sure that they do not deteriorate, depreciate in any way, shape, or form. And then no anticoagulants, no antiplatelets for at least 24 hours. And that typically extends to 48 hours, 24 hours. It's nice, I say ICU. It's really cool if you have a big enough hospital that has a stroke unit. It's a big thing in the civilian world. Not such a big thing in the military world. Not such a big thing. But these people on thrombolytic drugs need to be monitored constantly. What happens if you do suspect that there's bleeding? Stop it. When you get them over, they need to get another CT scan, make sure it's not bleeding inside the brain. Repeat all these types of labs and figure out what do we need to give them to reverse that. That's why we order that CBC, fibrinogen, type and cross, packed red blood, cryo, fresh frozen plasma. You get an idea of which type of intervention do we need to get. So, somebody comes in with a brain bleed, they are on an aspirin a day, they're gonna get platelets. They're gonna get platelets. And then consulting all these people. This is if we're having a bad outcome. We're having a bad outcome. Here's just another one. So most commonplace, if it is a massive middle cerebral artery, they're not a candidate for thrombolytic therapy. This is why you call a code stroke. This is why you get neurology down there, because they're going to help advise you. You should be making this decision in concert with them. So they can be a candidate to go and get decompressive surgery by neurosurgery. Whoa. Man, I just blew right past that. Not a single person raised their hand?
What?
The time.
I'm not lecturing that well, come on.
No, but you're almost
Sorry,
done.
take a break. My apologies.
No, you're almost done.
Blew right past that. I was getting into strokes. Another TIA, I saw.
I was trying to keep up. I need to start setting timers because I keep.
No belt, buddy.
BP. They don't have numbers. I'll just wait.
Just a little more succinct, but that works too.
What? Where did you go, you little shit?
Well, I mean, if no one else is gonna have it, I take it off.
No. I don't know. It does that sometimes.
So what was he saying about, like, I'm confused because, so like up here, we're saying no NSAIDs because they increase it, right? So that's why we're using acetaminophen that I was quoting.
No.
Right? He said that, he didn't write it. He said avoid NSAIDs because they raise your blood pressure.
I thought he said avoid NSAIDs because they affect your clotting.
He did, he also did say that. He said blood pressure too though, right? He said clotting. High?
I only heard clotting.
But I'm just confused, like, why we're letting them write out.
With the high BP if they're not getting thrombolytics, because they have a clot sitting somewhere, and if there's some blood making it around the clot to the rest of the brain, like you want to keep the pressure up, because if it's a lower pressure, no blood is going to skirt around that clot.
Okay. But
you guys think I'm interpreting this correctly? So
Somebody just transfer money out of your account.
that's what it's saying. But then if you look at that,
But plus
there's an
six-
extra W.
Yeah,
That's a scam.
that's
It's
a
plus
foreign
6 rate,
number.
Yeah.
Yeah.
I would call your
Schwab,
bank.
Yeah. Just make sure somebody's not trying to withdraw. They're trying to get you to say yes so they can confirm something to enter a password.
Yeah, I'm guessing they want me to give them
Yeah.
my.
But if you want to give anybody money, right here.
How do they know I have a Schwab account?
That's what I'm
They
saying.
just know things.
They
It's
look
creepy.
It's scary.
It's
There's a lot of
creepy.
Surprised how
public
much
record
everybody
information
knows
out there.
about these things.
Someone called my grandparents with a voice modulator pretending to be my brother
Holy
and like
smokes.
saying that he was in prison,
Yeah.
like in Connecticut,
That's why
and
when
they
they-
needed to wire him money.
Yeah, when they ghost call you and they're like, "Hello, are you there?" Don't say anything. 'Cause
They're
they
getting
take,
your.
They take your voice.
Yeah.
Yeah.
There's a solution to that. If that number's not in
Yeah, I don't answer.
It's not getting answered.
The only time I do, they're getting smart. They've started. If they notice a
They
Area
code
code.
that you answer,
Yeah.
they'll start using that. So they started using 414, which is Wisconsin.
Yeah.
It's bold
And
of
I
you to
used to
assume I'm
panic
the
and
wrong
answer
if it's
because
wrong.
I'm like, what if my parents are in a hospital? Like, and they're calling, you know what I mean? So I would answer, but I wouldn't say anything at first. I would just like pick up and they'd be like, are you there? I'm like,
My
"I'm
gut
fine."
thing is if it's that important, you're gonna call me again. If
And
it's that important, you'll call me again
with
in
the
5
new
minutes.
iOS transcribing voicemails as they're on, oh, that must be actually important. Let me go ahead and.
If it's a transcribed voicemail, all of a sudden I'll call it back. Like I just don't. I throw a lot of things in the spam. I'm like, absolutely not. Absolutely
But I would
not.
call your bank because they're clearly like probing you.
Phishing something.
Because it's usually me.
I mean, they have no access right now, so why?
To let them know, because also you can change like your online banking passwords, but then also like banks collect data on what kinds of scams are being
Oh
run
yeah,
on their
just to
customers,
help them out.
and like old people would definitely fall for that.
Yeah, we got another like 40 years out of the 40, 50 years before like people are make you
You have no cerebral infarction.
No,
Like,
that's fair.
I'm not gonna get into
I have an incredibly refined palate.
Clearly.
You know what I'm talking about?
Is it in the first third, middle third, or last third? Is it this one? Cerebral infarction?
It's before that. It's a little slide before that.
This one?
It's not gonna make you distinguish posterior from second. Okay.
I thought that was I think because they have really similar presentation. Both of them have a tax system.
And you said for Baszler, no dysarthria, Babinski, and sort of sleep training.
Dysarthria and Babinski are the two that I have written down.
He said something about slurring, but I think that's part of dysarthria.
What's that?
That's what
I think multiple different disorders have some. Oh, dysarthria is a motor disorder that affects.
Baszler.
We're looking at dysarthria.
Cool with my chocolate covering free. I don't want my chocolate.
Oh, I know what you're talking. That was further up.
It's not mimicking. It's
But I know. I yeah. I think I wrote that down.
I'm looking at
Yeah, like if it was an MCA, it's like more upper body base sign.
Yeah, see, I love how. See, everyone's intrigued. I'm waiting for It's good. Like, I want to try one. That's why I'm waiting for someone else. They're really bad.
You better do it the right way though. Like,
I know. I can keep up. I'm trying. I'm trying right now.
huh, who's colder now?